Awesome. Well, welcome everyone. As per usual, I have we have a lot of content packed in today's webinar, so I'm going to go ahead and get started. But today's session is being recorded and will be available for viewing afterwards as well. So don't need to worry if you miss a few moments of it. You will be able to access it later on. So we're really excited to have you all here for today's webinar on addressing ADLs in medical respite and recuperative care. So just a few sort of housekeeping disclaimers to start out with. We use the terms medical respite and recuperative care interchangeably to describe the same service. So some programs identify as medical respite, some recuperative care. Most of the time you'll hear me say medical respite care, but I really mean to encompass all of these programs. It's just a little bit of a mouthful to try to say all of those words at once throughout the session. So all of these different programs are reflected here. So our objectives for today, hopefully at the conclusion of this webinar, is that you will be able to demonstrate an understanding of ADLs and also what the different definitions of levels of assistance are. And then learning about how homelessness and health conditions can really impact independence in activities of daily living, or ADLs, especially for people experiencing homelessness. And then finally, hopefully at the end of this, you'll also have a good idea of some strategies to help support individuals who are not fully independent in ADL within medical respite care and recuperative care settings. I also want to give an acknowledgement. This is a complex topic without easy answers, which is one of the reasons why we're doing this webinar here today, is because this is something that comes up as sort of an issue or a problem in so many respite programs. So I'm not making any promises to have the golden ticket to the solution for this, but hopefully this will generate a good discussion and ideas about ways that we can address this better in respite settings. So I'm going to start out by defining what ADLs are, or activities of daily living, which most folks working in health services are probably familiar with. The definition that we're working with today are activities that are oriented towards taking care of one's own body and completed on a routine basis. I'm going to go through what these specifically are. So ADLs are several different types of activities, right? There's many things that we do to help take care of ourselves and our bodies. That includes bathing and showering, toilet and toilet hygiene, dressing, feeding, and eating and swallowing. And so these are differentiated here. So feeding is that sort of mealtime activity in which we set up the plate and bringing the food or fluid to our mouths, right? So either feeding ourselves, and in some cases when folks are caregivers, feeding others. Eating and swallowing is actually the physiological action of the body to be able to chew and swallow it and able to move it through your digestive system. So there's a little bit of a difference between those two. And then finally included in ADL are functional mobility, personal hygiene and grooming, and sexual activity. So these are activities of daily living. Sometimes there's a little bit of a blurred line between ADLs and IADLs, so instrumental activities of daily living. ADLs are those really basic skills that we need to take care of ourselves. And IADLs are some of those more complex tasks, such as health and medication management, meal preparation, shopping. We're not going into what that is today, but I did want to sort of discriminate and determine what those two different ones are. So when we're talking about ADLs today, we're really talking about bathing, dressing, grooming and hygiene, those really, really basic activities. Sometimes in the literature, the other way that you'll see ADLs depicted is at BADL, which is basic activities of daily living, which encompasses these same activities here. So when we're thinking about people experiencing homelessness, there's a lot of different things that can impact somebody's ability to do ADLs. I'm going to try to break these down between physical and medical issues, psychological and mental health, cognitive factors, and then finally environmental factors, because that's really a huge part of what's prohibiting some of the folks that we work with. So there's a lot of physical factors that can impact somebody's ability to do ADLs, from gross motor skills to balance to, whether or not you have tremors that impact your ability to tie your shoes or button a button, lack of sensation, decreased strength, decreased endurance. And all of these things can be their own diagnosis, or all of these things may be secondary to a medical diagnosis, such as having a stroke, diabetes, right? We see that a lot with folks who maybe have neuropathy and loss of sensation, obesity, arthritis, decreased vision, decreased hearing can all impact someone's balance, ability to see effectively and effectively complete their ADLs. And these conditions don't necessarily mean that they're going to cause a limitation in an ADL, but there's a lot of factors and symptoms from these diagnoses that could cause that. There are also cognitive reasons why somebody may have difficulties with their ADLs: memory, attention, executive functioning, which is a complex cognitive skill of being able to get started and initiate a task, organizing yourself, sequencing, following all the steps and following them in an appropriate order, and even finishing the task when it's completed. Self-awareness, problem solving, and the last one, ability to adapt and generalize, is a really big one. So a lot of us have learned routines and skills for doing things in a certain way in a certain setting. And if something changes, such as our physical ability or the setting in which we do them, some folks, especially those maybe with a cognitive limitation, aren't able to figure out, how should I do it differently given this new set of circumstances? So when we're thinking about people experiencing homelessness who've been hospitalized for an acute condition, this sometimes can be the biggest barrier. Well, I used to know how to take care of myself, but now I don't know how to transfer safely after I've had a lower limb amputation, right? So that ability to figure out what to do instead gets really impacted. And that can be a huge reason why folks struggle with doing their ADLs. Mental health can also really have a huge impact on completing ADLs. I think some of the ones that we tend to think more of or are more common are folks who have trouble with initiation, getting started, or decreased motivation, maybe folks who are disorganized and kind of all over the place. But trauma and PTSD also have a huge role in this, especially in how safe people feel in completing these very personal activities, especially if they're happening in a shared space or a space where they're not sure if they can lock the door or who else might be around. So that can have a really huge impact on whether or not someone feels comfortable with completing those. Cognition can be impacted by mental health symptoms. So somebody who may be more typically able to do it might have their cognition impacted depending on acuity of symptoms. There's also the adjustment disorder and adjustment factor. If you've had a significant health event and suddenly your limitations and your functional abilities have changed, sometimes the lack of doing ADLs is really a response to, I don't like looking at my body with this change. I'm frustrated with not being able to do some of these things on my own anymore. And that can really impact somebody's willingness to do ADLs or even their ability to do that problem solving piece and think about how to do it differently. Certainly people who are actively using substances, ADLs might not go into their routine or their priorities. And then certainly withdrawal can impact that as well, especially in certain cases, safety of doing ADLs. And then I also want to focus on the environment because environmental factors are one of the biggest pieces as to why folks experiencing homelessness aren't able to complete ADLs on a routine basis. So there's a lack of access to safe spaces and a lack of accessibility. So even if there is a space to do it, our folks, especially those who may be accessing services in medical respite, need places that fit wheelchairs and walkers or provide grab bars, and those aren't necessarily available in public and congregate spaces. Additionally, a lack of access to supplies. Grooming supplies are expensive, and so sometimes people may be able to do ADLs but not do them fully or to the extent at which they would like to be able to, or as thoroughly because of not having supplies. Additionally, adaptive equipment. So grab bars, shower chairs, long-handled sponges. There's a whole host of things people can use to make ADLs easier and more accessible, but those are expensive and they're not covered by insurance. So many people don't have access to them. And then not enough time to complete ADL. As we saw, there's a whole host of reasons why somebody might have limitations: physical, physiological, mental health, and that requires more time to do it. But if you only have 10 minutes in the morning to do it before you have to be off the shelter floor, or there's other people waiting for the space, sometimes folks will opt not to do it as opposed to rushing. And then again, disrupted routines and inconsistency in resources makes it really hard to prioritize that and make it part of the day and daily routines. And in some cases, when people need certain items, really difficulty self-advocating, especially for personal care items. People aren't always comfortable asking everyone that they see that, hey, I need toilet paper for appropriate toilet hygiene. I need incontinence supplies. These are things they're not necessarily comfortable talking about and have difficulty asking for and figuring out how to get them regularly. And so what does it mean when somebody has difficulty with addressing their ADLs? People will have decreased social and community engagement. Many times people are aware that they're not completing their ADLs and what the side effects of that might be, whether they appear disheveled or have body odor, and will then generally try to avoid being around other people because of that. People also face a lot of stigma and poor treatment. I think we've all experienced that, especially if somebody's malodorous. It can be harder to be around. Providers might want to move those visits more quickly to spend less time with the person, avoid offering services because the person doesn't appear to be caring for themselves. Exclusion from housing and resources. So people who are not considered to be independent and who are a potential safety risk may not be considered for certain housing opportunities. And it's unfortunate because in a lot of those cases, there's compensatory things that could be done for someone to be able to move safely within that space and live independently. Falls and fear of falling are another huge factor. Folks experiencing homelessness are actually at a higher risk of sustaining a fall than the general population and having this happen earlier. And fear of falling is actually a huge risk factor for someone sustaining a fall. And it happens a lot, especially if folks have had one fall. The fear of falling increases then risk of additional falls. People who have difficulty, even with sort of lower level or less intensive ADLs, are at risk for early institutionalization because communities lack supports to help people live independently in the community. And sometimes it makes it more challenging to talk with people about ADL limitations because they don't want to move into a nursing home at the age of 55. And then again, increased vulnerability and violence to theft, right? If someone appears to be vulnerable because of a functional mobility impairment or seems to have some cognitive limitations, that puts them at higher risk in the community for others. And what do we know about ADLs specifically for people experiencing homelessness and why this is such an issue and why we're seeing it crop up so frequently in medical respite programs is that people experiencing homelessness have disproportionate levels of chronic illness and geriatric conditions that increase the risk for functional impairment and loss of independence. So we have higher rates of this and it's premature. So folks have higher rates of these conditions and impairments, and it happens 10 to 20 years earlier than the general population. There's one study that looked at a cohort of individuals that had basically the same functional abilities and barriers at the age of 58 as equal to the general population of people in their 80s. So that's a huge gap in difference, and it happens a lot earlier, and it's happening, and that's why we're seeing it in so many of our settings. And it's also important to recognize, even despite sort of these early onset of aging conditions, environmental barriers affect all ages. So even our folks who are younger and maybe don't have the effects of these chronic conditions, this routines have been disrupted, and sort of that prioritization of ADL might be different because of the resources that they have. So this is a big issue for our population, and especially within medical respite settings. So now I'm going to talk about levels of assistance, and this is where things tend to get a little sticky and a little bit harder, especially in respite. So a level of assistance describes the amount of support a person needs to complete a task or an activity, such as an ADL or IADL. So I'm going to present the level of assistance really just in the context of ADLs for the purposes of today's webinar. But you'll see the same terms used to describe levels of assistance if we're talking about IADLs as well. So I'm going to run through these. And what I will say is, so independent is the one that we're all most common with, right? Is that a person completes the activity by themselves with no assistance from somebody else. But they can be considered independent if they complete this activity with or without adaptive equipment. So adaptive equipment, using it itself does not make a person not independent in an ADL unless they require assistance to use the adaptive equipment. But the device itself is not an indicator that someone isn't independent. And The definitions I'm going to say that I'm using here are ones that have been defined by CMS as a result of the IMPACT Act, which is a whole other sort of rabbit hole of information to go down. But this is the language that is being used by skilled nursing facilities, long-term care, post-acute care facilities. If you're getting documentation around levels of independence and assistance from a hospital, the language may be a little different because people are still using the FIM, the functional independence measure, to identify this. What I will say, although the terms are somewhat different, the idea is generally the same and the progression of support is generally the same. So it's kind of in a transition phase, which makes it a little bit difficult to if you're learning it, but if you go with these guidelines presented today, this is the language that's being used and will eventually be adopted by most hospitals. So following independent, we have setup or cleanup assistance. So a person is helping set up or clean up, and then the individual, the patient, completes the activity. So the support only occurs prior to or following the activity. So if you're the provider or the helper, you could get the person set up and walk away, and the person could complete the activity, and maybe they just need assistance with cleanup at the end. So this isn't independent, but it's a lower level of assistance required. Then you have supervision or touching assistance. This could be in the form of verbal cues or light touch or steadying, or what's called contact guard. It's kind of like walking with your hands very close to but not on the person, to help the person complete the activity. Assistance may be provided throughout the activity, generally intermittently, so not continuously. I like these definitions because you'll notice that assistance can come through verbal cueing as well as physical support. So sometimes the assistance required is more in terms of verbal direction as opposed to like actually physically supporting the person. Then we have partial and moderate assistance. So the helper or the provider does less than half the effort. That helper might lift, hold, or support a trunk or limbs, but again, not more than 50%. So in some cases, transfer is an easy way to talk about it. If you're assisting transferring the person, you're not holding more than 50% of their weight. You may be guiding where their movement is going, but they're doing most of the strength action. If we're talking about verbal cues, this might be that you're providing verbal cues kind of step by step throughout the task, that if it's just intermittent, it's not enough to guide the steps of the process. And then we have substantial and maximal assistance. So the helper does more than half the effort. You might help lift or hold trunk or limbs and provide more than half the effort. So more than 50% of the person's body weight, more than 50% of the actions are guided by the helper. And then we have total assistance, where the person is really not able to extend any effort to complete the activity, and it's the helper that does most of it, or that the person requires two helpers to be able to complete the activity. So these are a lot of different levels here. What I want to kind of focus on as we're talking through this conversation, and I'm going to give a couple examples in a minute, is thinking about that setup or cleanup assistance and that supervision or touching assistance, and thinking about, is that something that's navigable within the medical respite setting, right? Because that doesn't necessarily propose a significant safety risk. It doesn't require handling of a person. And this is sort of that gray area. And part of the reason for thinking about this, right, is that we know that these folks are coming into our programs. And so thinking about how do we best support them. Again, a complicated topic and issue. When we're getting into that more substantial, the mod, the max, certainly the total assistance, that's where we're starting to fall outside the scope of medical respite care. Because if somebody needs that level of support, they likely need a different level of care. Again, lots to think about and sort of digest here, and we have some time to talk through it. So going to talk through some of these ADLs impacting respite, and what does it look like, and what are our opportunities here. So part of it that we need to think about is, what are our environments like, and how are we contributing to impairment, or how are we supporting functional independence? So sometimes the inability to do an ADL is really a mismatch between what their abilities are and what the environment is, right? So somebody might be independently mobile when using a wheelchair, but if their environment is full of stairs, they might not be considered independent anymore, right? Because they require assistance to get up and down those stairs. That's not the person's mobility skills in that case, right? It is the environment that's preventing that independence. We also need to think about that folks might be minimizing the supports that are needed because they don't want to appear vulnerable, because that's a risk for victimization. They don't want to jeopardize housing options. Again, if you're not perceived as independent, people are going to question whether or not you can live in your own place in the community. And we sort of have these barriers set up that people don't want those barriers and they want to move into their own place. And people don't want to be institutionalized. They don't want to go into a nursing home, when they're younger, because they need a certain level of assistance. So there may be some minimization of supports needed for those reasons. We also, as I mentioned, programs, this is coming up because programs are getting referred people, and when they come into the respite program, they're not independent, even though it was indicated they were independent at the admission process. Some of this might be the hospital trying to pass somebody off because it's a difficult discharge. It's not to say that that doesn't happen, but sometimes what's happening is that decompensation can happen when somebody moves from a highly structured and supportive environment to the community. So the person may have been independent in getting in and out of bed and in and out of the shower in the hospital because they had a hospital bed that could lower or grow higher as needed, that the toilet in the bathroom was higher, so it was easy for them to get on and off of it using grab bars. The shower had a shower chair with grab bars. So in that space, the person is independent. If they move to a community environment where there are more demands, they might be revisiting some stressors, and it's not set up in the same way, then we'll see some decompensation. And it's not that anyone was disingenuous, could be a natural pathway, but suddenly a respite program has someone that might need a little bit more assistance. Additionally, even if the person has a pretty comprehensive eval before they transition to respite, it's not always possible to predict how skills will translate. If somebody has a decompensation in mental health, they may have a decompensation in physical health and mobility and functional independence as well. And that wasn't clear or indicated in the hospital setting. The other really hard part is that when people are doing an evaluation in the hospital, they're mimicking what somebody's home environment might be. Many people in the hospital, unless they have lived experience or a lot of awareness of homeless services, don't know what that home environment looks like. They're basing it off of people who are housed and who maybe have resources. And so without really a clear, comprehensive description of that, they might not be able to assess whether or not the person is going to function in their discharge environment well. So there's a lot of reasons why this comes up and why respite programs see folks who need more assistance for their ADLs. The other thing to consider when we're talking through all of this is that not all ADLs are equal. So we kind of group them all together in these categories, and we group the levels of assistance all together in these categories. But when we really think about it, right, assisting someone for bathing is a different task, a different level of support needed than someone who might need assistance for grooming. So I'm going to try to highlight that here. So for someone who needs an assistive device or increased time for bathing, right, they might need longer in the shower. They might need tools such as a shower chair, a grab bar, a long-handled sponge, and they may be a fall risk if this equipment is not available. For grooming, this might mean that the person needs adapted fingernail clippers or supplies with built-up handles to be able to hold and grip these differently. So there's not necessarily as much of a safety risk in grooming if someone doesn't have the adaptive equipment. When we're looking at setup or cleanup assistance, right? So this might be that the person needs, hey, so-and-so, it's time for you to go get in the shower this morning, right? Just a basic reminder, one cue, hey, it's time to go do this, right? Or for somebody who's transferred into the shower space because of mobility limitations, they might need someone to hang the towel up within reach, make sure the soap is within reach, or turn the water on. Because there's so many showers, even if there's a shower chair, the person can't actually reach the faucet to be able to turn it on, right? Basic setup doesn't require touching the person, doesn't require an expensive energy on the part of the helper, but it does help the task get done safely. For grooming, again, that could be a verbal cue. Hey, it's time to go brush your teeth. Or it could be making sure that the person, especially if they're disorganized, has everything they need before they get started to be able to start and finish the process effectively. If we're talking about supervision, this might be somebody, or touching assistance, this might be somebody who can't reach a specific area. If there's a limitation in shoulder mobility, they might not be able to reach behind and wash their lower back in the same way, or balance issues, be able to bend down and clean their feet, which could be problematic for someone with diabetes or wound care needs, or for someone who needs a little bit more executive functioning guidance, a reminder to use the soap and shampoo while they're showering. And that's what that level of supervision would look like. Similarly, for somebody in grooming, it might be squeezing out toothpaste, combing your hair, or just making sure that they were thorough. Like, oh, did you wash your face fully? Oh, I see, a little spot, like go check the mirror again, giving that sort of verbal cue. When you get to partial and moderate assistance, right, this is where we sort of make that jump in intensity of support given. So the person would require somebody else to wash multiple areas of the body, right, or require somebody to be there observing to make sure the task gets done from start to finish in the shower. In terms of grooming, this might be somebody is required to do majority of the task. So they're unable to cut their own toenails. So the nurse or whoever would have to do that for them, or step-by-step cueing again throughout. And I highlight this jump here, and I actually don't go further in examples of substantial max assistance because that is really beyond the scope of what we could do in respite, is thinking about though, what is the difference between the supervision part and the moderate assist part? And again, sort of that line of, could it be within the scope of the staff we have on hand to provide some of that supervision assistance versus getting into this moderate assistance where it is more intensive, and we might need to build up our supports around that should we have someone in our program that requires that level of support. So I'm going to continue to hash this out, and we're going to compare between transferring and eating. And so with transferring, again, the person might need more time or need supportive devices to do it, such as a grab bar or a commode with handles on the side. In terms of feeding, this person might need non-slip dishes, built-up handles, or softer foods. Both of these things, although requiring adaptive equipment, could be relatively accommodated, right? The person is doing it when they have the right materials and space. In this case, though, setup or cleanup assistance, perhaps the provider would need to position a sliding board for a person to use it to transfer, or a visual cue to know sort of the appropriate angle to line up their wheelchair to move from the wheelchair to the bed safely. That takes definitely a different level of skill than when we're thinking about setup assistance for grooming, where it's just making sure the person has gone into the bathroom with their washcloth and their toothbrush and their toothpaste, right? So again, differentiating between these ADLs and sort of the complexity that each one of those presents. When we're thinking about setup for eating, right, this again might be someone who needs you to open containers or lay out stuff in a visual field to make it easier for them to see, to be able to pick it up easily, but they can eat by themselves once it's set up. For transferring, if we're talking about supervision or touching assistance, again, this might be a small amount of physical support, again, helping the person set up and make sure things are appropriately angled to increase safety. Again, that's a little bit more of a complex skill. And then when we're thinking about supervision or touching assistance for eating, the person might, and feeding, the person might require assistance, such as moving the food from their plate to the lips or setup of a plate and utensils. And again, highlighting this is getting into pretty intense assistance, right? If someone actually needs assistance to be able to feed themselves, we have to think of that accommodation versus somebody who needs, someone to cue them to make sure that they comb the hair all around their head, right? Like grooming is a less skilled ADL than feeding and presents with different safety concerns if the person needs assistance. Partial or moderate assistance, again with transferring, that's when we're getting into physical transfers that the helper is really supporting the person from point A to point B. And again, that's a higher level of skill and scope of practice for someone to be doing and to do it safely for the client and for themselves. Feeding, again, is that they might be able to feed themselves simple items, but need assistance to manipulate utensils, prepare food for eating. So both of these examples, right, are likely beyond the scope of your medical respite program. That's kind of the line we need to hold. But then again, going back to that lower level supervision or touching assistance, In feeding, again, that might be a line because feeding and eating are so basic, again, versus grooming or showering, where I'm going to get the task set up for the person, but then they're able to do it independently. So I'm just sort of planting some seeds for thought here, not necessarily answers about what and how you should be doing it, but wanting to think about these nuances of, instead of independent or not independent, thinking of, well, where, again, what's the support and how could we do that to be safe and to maybe help a different number of people. So I want to talk about barriers and opportunities for addressing ADLs and medical respite, right? So I'm going to start with the barriers, and these are things that I think we know. That when we require independence in ADL, limits admissions for those who might benefit from medical respite when the need for assistance is low, but it's, the person is not independent. So it could be a potential barrier to care for folks. But we need to be careful, right? If we change what type of assistance a person needs in the respite setting and our admission requirements, that can blur the lines with referral sources. And some of referral sources we need to be stricter with, right? Because they're already pushing these lines and already pushing these boundaries. So we don't necessarily want to give more space to have people that we can't manage in our programs. And then, of course, if you're providing increased assistance, there's absolutely the potential for increased safety risk, and that shouldn't be taken lightly and definitely warrants consideration. And in some cases, is going to require an investment in staff and available equipment for folks to use. So, we might not be able to wake up tomorrow and say, we're going to help more folks, who need a little bit more assistance in showering. That needs to be intentional and thought out with the appropriate supports. So then if there's all these barriers, why are we talking about this? Why is this important? There's a gap in a lot of communities for people who don't qualify for skilled nursing level of care. So somebody who needs, supervision just in grooming or just in dressing or sometimes even just in showering is not going to qualify for skilled nursing facility. That's not enough assistance needed for them to be referred, in addition to any of the other barriers that folks experience with getting into skilled nursing. So, without respite, taking those folks, where do they go? It also provides an opportunity for people to be able to really hone in and redevelop these functional skills and adapt to changes. So, if we have a space for people while they're getting other medical issues treated to be able to practice doing things a little bit differently, that's going to increase their safety when they go back out into the community. And it gives an opportunity to address some conditions and prevent further functional impairment for folks. Instead of letting that progression happen, if we have respite to address some of those things, the person may be healthier, and then those limitations aren't going to happen or happen so quickly. And again, thinking about what we know in gaps in services in the community, medical respite, when set up appropriately, is maybe going to be more safe and accessible than other discharge environments. So that gap of folks who don't qualify for skilled nursing care, they don't need that much assistance, not accepted into the respite program, often they're going back into the shelter of the streets, right? And we know that most cases that environment is even less supportive. So thinking about the opportunity again for respite to fill that gap a little bit. As I said, doing so doesn't come lightly. There's some things that should be considered with that, right? So does the medical respite program have adequate facilities and staffing to support ADL management in their patients, right? If you have a pretty skeleton staff and it's, case managers who aren't trained in these things, then it's maybe not the right choice. But if you have potential to staff up people who can learn some of these skills within their scope of practice, some of these modifications are easy to implement. It's totally possible to think about that. And thinking about your admission criteria, if it's a strict has to fully be independent, or could we move the line a little bit and make sure we're saying independent with use of equipment? And that use of equipment, again, has to be accessible within your environment. And maybe you can take them if the hospital supplies it, right? And also thinking about what ADLs could we support if the person needs more independence, and what is a hard line? Absolutely not. I continue to give the example of feeding and eating because that's such a basic self-care skill that if somebody needs assistance for that, aside from like opening a milk carton, that's pretty substantial, and that might be a place where we're not going to budge. But again, that grooming piece and even setting up for showering or assistance with dressing, if we provide supervision, is that something that can fit within our scope? And when we're thinking about, should we do this? Why? Should we change some of our practices, staff up more? Think about, is this an health equity need or a gap in our community? Is there somebody else providing this service? Because if there is, we don't need to do it. But if there's not, thinking about what's appropriate for us to be able to fill and what can we do to start taking some steps to address this within our setting. Again, you're not going to go from 0 to 100 overnight, but what are some things that we can do? So I'm going to go through and give a lot of examples of some of those things that could be done potentially. It's a lot. And what I will say, and I don't know if I said this at the beginning, is we have clinical guidelines. I will drop in the chat the link to that at the end of this, available, that provide these recommendations so you can reference them as well, instead of sort of memorizing them all day today. So the first thing we always want to do is take a trauma-informed care approach, right? And so when we're looking at our spaces, do people have private spaces? Do they have, are they able to take extra time to complete their ADLs so they don't feel rushed or like somebody's going to barge in on them? If you're talking about ADLs with the person, making sure you're in a private space so that this isn't something that the whole respite community knows that the person is struggling with. And if you are going to provide any form of assistance, always, always, always get consent before providing it, before the activity begins and moving to a different step of the task. Whether at any point, always ask for consent. And again, understanding how these conversations might be difficult. I've talked through a lot of these bullet points, but when you're approaching the person to talk about difficulties with ADL, just understanding that perspective of where they might be coming from and why they might be hesitant to talk about it with you. I also want us to address and think about bias. It is very easy to think that ADLs should be completed in a certain way. And there's really not a wrong way to complete ADL if you are at the end goal, your body is taken care of. So when we're thinking about who's having a problem with ADL, it's always good to check in with ourselves and say, is it a problem or are they just doing it differently than I perceive ADLs should be done? And that can be cultural. That could be as a response to people having to modify their routines because of being homeless and lack of supplies that they might have, right? There may be a whole bunch of reasons, personal preferences for doing certain things. So it's always important to ask the person, what are the barriers that they perceive that they're experiencing, and what about their routines have been disrupted and impacted, and not going in with a preset idea of what routines should be. It's always helpful to ask too, what would your routines look like if you didn't have these barriers, right? Like, what is your preferred way of doing this? How much time, how frequently, right? Some folks prefer to shower 4 times a week regardless, and that's their appropriate routine. So kind of talking through that and getting to know that for the person, as opposed to putting our own assumptions on that. If we're taking this approach as a team, right, there should be communication among the team. If we're using certain strategies, being consistent, that's how people learn and are able to use strategies effectively. Use destigmatizing language when possible, person first, and also just, not focusing so much on impairment as much as support needed. Making sure discussions are private, coordinating care, especially if certain referrals are needed, and including the person in discussions and next steps, right? Whether or not it's an inappropriate level of care and respite and they need to be transferred out, including them in that discussion so they know that that's happening, or that referrals are being made, or even to identify what strategies they would like to use and try. This is just an example of different roles that different staff within the respite program could take. This isn't an end-all be-all list, right? But nursing can certainly support through doing a fall risk assessment, helping support and implement strategies identified, making a report so that if the person does need a certain discharge environment, that's documented and sent to the appropriate places. Primary care and medical respite providers can do an initial exam to address some causes. Some things might be happening that are undiagnosed, refer to specialists as needed. And again, that documentation status to support an appropriate discharge environment, to help access assisted devices as needed, and document disability status, especially for folks who are working on SSI claims. Case management and direct staff, so folks, kind of seeing clients day to day on the floor. You might be the person figuring out what their concerns are. You might be the person noticing that there's things, ADLs aren't happening, or that the person is having trouble with it. can support with getting to these different referrals, and also in acquiring supplies, both ADL supplies or adaptive equipment supplies. And again, community resources. If the person's limited in mobility, one of the resources they need is accessible transit, right? Which might look a little different than folks without that. And again, helping coordinate to appropriate discharge placement options as identified. And community health worker and peers can support that. Again, might be sort of the first people to have that conversation because that's who clients are most comfortable with, and supporting talking about these concerns at medical appointments. And then behavioral health, certainly if there's symptoms that are impacting ADL, but also, again, if this is sort of newly onset for a person, identifying their response to their changing capabilities and that adjustment to potentially feeling disabled, which can be really hard for folks initially. And then using motivational interviewing. So if we're engaging the client, kind of going through these client person-centered strategies here, what are their perceptions? What are their concerns? What are the supports that they need? And this is, again, just an example of questions that you could potentially ask, because sometimes people aren't perceiving it as a difficulty, and that's important to know too. And wondering how and what type of support they would like within the respite program. So if you are the nurse, PCP, or respite provider, these are different things that you can do to help address what's going on with an ADL. You can also assess for a whole host of barriers, right? All those barriers I talked through at the beginning, identifying that those might be going on, and and potentially underlying causes that could be treated for it too. And then also thinking about duration. Is this new? Is this something that will change if the person heals? So maybe I have difficulty getting in and out of a bathtub because I have lower leg wounds, but that will not persist once those wounds are healed. Or is this a long-term change that we need to revisit strategies and supports? So this is one tool, the CATS Index of Independence and Activities of Daily Living, that can be used to screen, especially for documentation and if the person needs a higher level of support. The downside to this document is that it is sort of a binary yes or no. Either the person is independent or they're not. So it doesn't reflect any of those nuances we spent lots of time learning about earlier in the webinar. But so it's not necessarily helpful to identify those those different levels of assistance, but can be helpful as an initial screen to be able to support maybe a need for more intensive referrals or support. All right, so some strategies, and hopefully, again, this isn't an end-all be-all list, but some things that you can take away to help support clients within your space. So the first thing, of course, again, engage the client. Everything you do should be determined with and by the client. Maybe you're giving them some ideas, but they have to be agreeable to trying them. The other thing you have to think about is who of the staff is going to be able to support this. So who has capacity and time in their day? Whose skill set does it fall in scope of practice, and who's the client comfortable with? Again, some folks are not comfortable with an opposite gender assisting them with ADL. Sometimes it's same gender, so just certain staff don't feel comfortable. So making sure that that fit in is a good match for the individual. So some things that you can do is establishing a schedule, right? So identify with the person, when do you feel most energetic, alert, so that can increase safety in ADL. When can you take the most time? Sometimes it's showering at 10 o'clock in the morning because not everyone else is trying to get into the bathroom. Establish a set time to help build that routine around starting activities, and using a checklist or reminder to help make sure all steps were needed. You can help the person set up their ADL, organize their supplies. So especially if someone has a mobility limitation, it can get frustrating if you forget something and have to go back and forth. So just making sure, like, do you have everything you need? Do you have a towel? Do you have your shower socks? Do you have, your shampoo before you go in? And then verbal or gestural cueing, again, to prompt the person to use the strategies identify, or to even start their ADLs at a certain time. So these are just two examples. Again, you want to go at the recommendation of the client, but thinking about morning routine. This is something that could be posted in the person's room by their bed to help them start and complete those activities throughout the day. Additionally, organization of personal belongings. If you are someone, who has to keep your belongings with you, all of them with you at all times, it's hard to stay organized. Respite might be an opportunity to do that, making sure items are in an easy to access location. So you minimize bending and reaching, especially for things you use frequently. And also thinking about alternative methods for ADL. So if you have a person who's not safe to shower in your program, and you're waiting for a potential discharge placement, you might encourage sink side bathing, or using personal wipes or baby wipes for most of the cleaning, so that people aren't having to shower every single day. There's also dry shampoos, baby powders, cornstarch, using mouthwash instead of toothpaste, a lot of different things that could be used alternatively if certain activities aren't safe. Again, these are just different ways to organize personal belongings. Little shower caddies are nice, so it's like pick up and go. I don't have to think about it before I'm moving into the shower space. And then accessible clothing options, especially as a person is healing, for some of these more short-term, pants that are easy to pull on, shoes that don't have laces, because tying shoelaces is actually really hard and can be a fall risk if they're not on properly. Cotton t-shirts that stretch that are easy to pull on. Button-down shirts are easier for some people instead of pulling it on over the head. In other cases, people can't manipulate buttons. So, just sort of thinking through for each person, what's going to be most helpful for me to be able to do this independently. And there's a lot of great adaptive equipment out there to support dressing that an OT or PT can recommend. The environment, again, right, I've talked about this a lot, is a huge barrier for a lot of people. So thinking about in assessing the environment, this is a check to make sure that your safest space for people, really a universal design approach, is safe for everyone, right? Do people feel safe? Can they lock the doors? Are they cleaned? Are the floors dry? Like, do we have proper drainage? Can somebody with a physical limitation move safely? Is there a place to put supplies? You could have a shower chair and you could have the faucet within reach, but if there's no shelf to put supplies on, then you have people bending and reaching and trying to pick things up or hold it in their lap, which complicates it quite a bit. Can they hang their towel without getting wet, and can they reach it from the seated point? So sort of some things to think about in how the space is set up. Making sure there's discreet and safe places for people to dispose of products, and supporting people in accessing supplies, making sure hallways are clear, spaces are well lit to prevent falls. And again, can people reach these spaces, especially from different heights or basic seating apparatuses? Accessible bathrooms. And again, you can actually have a consultant come in and do an environmental assessment for you, but some basics are shower benches and shower chairs, which are good for everyone, grab bars hung in appropriate and ADA spaces, space to hang your clothes, hang your towels, non-slip bath mats. They're ones that are machine washable, but also non-slip shower shoes are a great option for people. They're individual. You don't have to worry about washing them as frequently. The person is responsible for them. And then again, access to sink and hygiene spaces, making sure people at all heights and mobility devices can reach these effectively. So this is a picture. It's a beautiful accessible shower, except for the tub part. It's for a person to step over the tub. But just thinking about, there's a lot of different grab bars in here, so people could grab them at different, depending on where they are and what they're using, which is really nice. And proper drainage is another really big piece. This is another great option if you have a tub space and not a walk-in shower space, ones that sit over the edge of the tub so the person can sit on them, sort of scoot and lift their legs in instead of stepping over the shower. And then this one, again, beautifully designed. Of course, this is like not probably in real respite spaces, but there's some nice things about this. There's only a small lip for a person to step over. There's a shower chair, which has the arm rails on it, which is a nice alternative if you don't or can't install grab bars in there. None of those spaces were perfect, right? But they offered a lot of really good things. And then again, another thing to think about, are grab bars in a safe space? Can people manipulate, move in and out of the spaces? I don't know what the one really tall grab bar is that's away from any seating. I don't know who that would help. So always good to think about sort of the usability of some of these features. Another really nicely designed one, but again, there's not a place for the person to push up off the toilet. So even our examples aren't always perfect, but can provide a lot of support for folks. Again, when we're setting up the environment, setting up for grooming, lighting, and then self-care items again, and having a variety and being thoughtful about these. So mouthwash, specialized soaps, oral care, floss, nail clippers, adapted nail clippers, things that people don't regularly have access to can be really helpful for them to be able to do their ADLs in the respite space. I think I've talked about a lot of these, so I won't go over that too much more. And again, these accessible pathways, clear of clutter. So I won't read these to you, but thinking also about furniture height and automatic doors, or even just using handles, because those are easier than a twist knob. So there's some little things that you can do, and certainly some bigger structural things. So what do you do if somebody comes to your program and they need more support? If they're at your program, you can refer them for home health or home health aid if eligible. There's certainly some barriers for folks in accessing this, but if they're eligible, it might be a good support, and they can see OT or PT. For some folks, a transition to skilled nursing care might be the most appropriate. And sometimes we don't think about this, but we can build liaisons with skilled nursing facilities too, that once a person is there and they, sort of achieve a certain level of independence, they may be eligible to come back to the respite program, right? We can be a continuum from that. And sometimes that can make that a little easier, or SNFs more willing to take folks if they know there's a place to discharge. There's also certain waiver programs in communities for assisted living that can certainly be limited, but in some places is an option. And again, just a reminder to always use trauma-informed care and a strengths-based approach with who you have. And other things, only provide assistance within the skills and licensure of your staff and facility, right? So don't start helping people transfer if your team hasn't been trained to do that and is not within their skilled license. Again, when we're looking at those levels of assistance, focus on the levels that are appropriate within your space. And then you can work with partners if this is something you're wanting to pursue and do that level of training, you can work, there's rehab departments at hospitals that can help provide that training for your staff to be able to provide some of this assistance more safely. And always make sure you have policies and procedures and responses if a person experiences a fall. And also, hopefully this would never be needed, but for clients to report misconduct if someone was unsafe in handling them or was inappropriate when working with them in ADLs. Again, I would hope that would not happen, but we need to have those procedures in place. And who is responsible for this could fall into, again, a certain number of staff depending on licensure, but these are just some examples here. And then specialty referrals. Again, these are all the different things that OT, PT, and speech can do and assess and provide support and help, even if you aren't comfortable coming up with the strategies with the person yourself, right? That may not be in your scope of care. You can have these providers give those strategies, develop them with the client, and you can help reinforce and implement them in the respite site. And then specialty referrals, again, to address any of these underlying conditions or behavioral health needs that somebody may present with. All right, I have a case study and I'm not sure we're going to get to it, so I'm sorry. Trying to go through these things. Discharge planning is probably the most difficult part of being a medical respite program. But when we have people who need support with ADLs, we have to think about the accessibility of potential discharge options. What is the person eligible for and what are they willing to go to, right? We, at the end of the day, have to respect client choice. Thinking about what equipment the person has been using on our respite site and is that available where they're going? Not a lot of shelters have necessarily accessible bathrooms and shower chairs and aren't going to allow a person to bring their own. So that's definitely a consideration. And then again, part of that continuum, who's going to keep following up with them to provide services and address some of these underlying conditions and make sure that the person doesn't decompensate or lose some of the skills gained. Yeah, and then there's room for advocacy, right? We've identified tons of gaps in care here. And so there's a lot of things that we should be thinking about doing. I'm not going to go into because we're going to publish some resources on this, but thinking about who do we need to work with to make some of these higher levels of support more accessible for the people that we work with. These are examples of advanced training. All right, so we're going to get to Barbara. a little later than I intended, but we have Barbara, who's a 54-year-old who identifies as female. She was referred after hospitalization for a fall, exacerbation of diabetes, and an unhealed wound at her amputation site. She was transitioned to medical respite with a goal of healing the wound and attending PT appointments. So she has left-sided weakness from a previous stroke. She has the right below knee amputation and had not successfully made it to PT appointments previously to have a prosthetic fitted. She's lost her housing when she was hospitalized for the stroke. So there's certainly probably some trauma related with that. Has lived with a close cousin, but the cousin is on a second floor unit, which is not accessible, but her goal is to return to independent living. Once she gets to the respite, there's inconsistencies in her report saying she's independent in ADL activities, but also then asks for assistance from staff and other residents, and sustained a fall while transferring into the shower, although did not have any long-term injury. So here are some questions here. If you all would like to, let's see if I can put the link in the chat here, sort of go to, I guess we'll do this just through our chat. So thinking about what actions could your program take to support Barbara? What changes might you need to make within your program to make the space accessible? And what screenings or referrals would you consider? So feel free to post your answers into the chat here in this webinar. Ignore the Menti link there. But what would you guys do if this happened at your program? Shower chair, yeah, is it sort of an easy, not easy, but kind of an easy basic one that can be really helpful, especially if that kind of goes over if you have a tub over the edge of the tub so she could sit and slide onto it. OT consult. Thanks, Tyler. Yeah, absolutely. I'm an occupational therapist. I should have disclosed that at the beginning. Yeah, that would be a great time to ask for a consult with physical therapy and OT for her mobility and her ADL challenges. Any other things that screenings or referral you might consider to work with Barbara, both in-house or outside of the respite program? Housing, yeah. So she's identified independent living as a goal, right? And so when we're considering housing, thinking about accessible housing spaces, you know, places without stairs or that, you know, have showers that she could access, elevators. Great. Any other thoughts about how we might support Barbara? Home health, yeah, potentially if she was eligible. You know, it was noted to me that sometimes home health agencies won't provide services if the person is in a shelter setting, which is an unfortunate barrier and space for advocacy. Orthopedics, yeah, absolutely, for the prosthetic, for the wound. Great, lots of options. So I'm going to share what happened with Barbara. This is based on a case example. This isn't necessarily the way that it has to happen, but this is what progressed with her. There was a cognitive assessment, partially that happened because of her inconsistency in reporting independence, but also you know, asking for assistance, and then because of the stroke. So that identified that there was some mild to moderate cognitive impairment that gave her difficulty with planning and problem solving. She was also assessed by behavioral health. Again, some of that inconsistency, but also identified in that assessment, identified a fear of falling, some low stress tolerance, again, as a result of that trauma experience from having a stroke and losing housing. Working with the interdisciplinary team, so worked with PT for a mobility assessment and recommendations while she was being fitted for the prosthetic leg. So things that can be done now while working towards that future goal, and working with OT to assess ADLs and have strategies that she could use while within the respite program. And so the support plan was then she was supported in being able to use those adaptive strategies identified by the PT and the OT in the respite setting for transfers, for dressing, and for bathing. And then the staff were able to help compensate a little bit for the cognitive deficits, to have a structured time for showering, so she had more time. And if she were to feel stressed or like she needed assistance, staff might actually be available to help her. And then some support to help her organize her space and be able to plan ahead, so she wasn't sort of stuck in a position without what she needed and unable to get it in that particular setting. So final thoughts and considerations. I just want to throw these out here, and I'm sorry that we don't necessarily have time to discuss as a group because we are at 3 o'clock. But when you're moving forward with this, just thinking about what we are and what we are not, respite is not an unlicensed skilled nursing facility for people experiencing homelessness. So for those that really do need that higher level of support and benefit from those services, that's where we need to hold our line and have people go and do our advocacy work to make those a better fit for the people that we serve. And if you're thinking about doing more to support people with ADL, definitely think about what training you need, what's within scope of practice, is there a certain level of licensing needed? And thinking about what's the mission of our organization, who are we serving and how can we serve them better? And how can we safely adjust to support those in need? So I thank everyone for coming. I don't want to hold us past our time. Julia dropped a link for a survey. We would love to hear your feedback on this session, again, so we can continue building out resources for all of you. But if you visit our website, we do have the clinical guidelines published. So there's a 5-page publication, and we will post this webinar and slides, I think within about a week as well on our website. So all of these things will be available. Yeah, so please check out our resources, and thank you everyone for coming. I'm happy to hang on for one more minute for anyone who might have questions, but otherwise appreciate all of you for joining us today and hope to see you at our future webinars.